Hey guys, welcome back. This is Russell Linville, of course, and it is nearly the new year here in Minnesota, and that means you guys are still on break. And so a couple weeks from now, I will be up there. About 3 weeks from now, I'll be up, or I should say down there, with you guys in Arizona, and hopefully with this surge in COVID situation going on, I will be there and meet you guys and help out best that I can. So what we're going to do now is go over differential diagnosis of the elbow. And much like the shoulder lectures, we have 3 lectures. It's the first of 3. And we'll be looking at contractile tissue, which is this lecture, inert tissue, and then some compressive neuropathy issues in the elbow. So this is one of 3. And so let's dive into it. And of course, reach out with any questions. You guys have been doing a great job of that all term, and I really appreciate the questions. I try to get back to you as soon as possible, obviously. And so without further ado, let's get into it. So what we're going to learn about today is tendon injuries for the most part. The big 2 are epicondylalgia of both lateral and medial origin. So you know this as tennis elbow and golfer's elbow probably, and so we will dive deeper into this. We're also looking at bicipital tendinosis as well as distal biceps tendon rupture, and likewise on the opposite side of the arm, we're going to look at triceps tendinosis and triceps rupture. So not a lot of differential here, but the most common contractile tissue issues, if you will. Epicondylalgia. We call it epicondylalgia because the suffix algia means pain. And so for a long time we've called this epicondylitis, but as you'll learn on the next slide, there's many different causes of lateral elbow pain or medial elbow pain, and so we've now termed it epicondylalgia. So lateral epicondylalgia is known as tennis elbow. It's a pathologic condition of the common extensor muscles at their origin of the lateral humeral epicondyle. It involves the tendons of the muscles that control wrist extension and radial deviation. As you will learn later in this lecture, wrist extension, radial deviation go together, and so does wrist flexion and ulnar deviation, just because of common muscular attachment sites that help with those movements. Tennis elbow affects 1 in 3% of the population, occurs most in 35 to 50-year-olds, so middle-aged individuals, and usually it's their dominant arm. The extensor carpi radialis brevis is typically the primary site of injury here. However, the radialis longus, the extensor carpi ulnaris, and the extensor digitorum communis also may be involved. So the mechanism of injury is usually either macro or micro tears in the common extensor tendon caused by repetitive overuse of the wrist position in extension. And so one of the reasons that this is deemed tennis elbow is because when you swing a tennis racket, your wrist is never really in neutral position. It's usually in a little bit of extension. So as you come through, especially the backhands, the wrist is an extension. And so what you guys may know already, and if not, I'll enlighten you, you get better grip strength with slight wrist extension. That's just because it allows your digit flexors and your wrist flexors to activate better. The length-tension relationship is better. So a little bit of wrist extension actually improves grip strength. And so doing that over and over again in a little bit of extension may cause lateral epicondylalgia. But over 25 conditions have been suggested as causes of lateral elbow pain, including periostitis, infection, bursitis, osteochondral defects, radial nerve entrapments, neurogenic causes, even cervical spine involvement with things like radiculopathy, and shoulder involvement. So weak or tight shoulder may place more stress on the elbow during functional movements in sports, causing an increased stress there. So the big thing here is patient history, signs and symptoms. It's pain in the lateral elbow. So essentials for diagnosis here. If you get somebody that comes into your clinic, lateral elbow pain on their dominant arm with activity, that's middle-aged and is tender to palpation, you can pretty much guarantee it's lateral epicondylalgia. However, as we say in the biz, if it looks like a horse and talks like a horse, don't think it's a zebra. Meaning, There's a lot of different things that may cause lateral elbow pain. We went over a few on the last slide. But the most common is true lateral epicondylalgia. So, again, with these slides, these are slides that are designed for you to read through and take the most pertinent information, as well as read Dutton. The big bullet points I will highlight or bold, however you're responsible for all of it. Signs and symptoms usually is insidious onset of pain, no true mechanism of injury. And again, you got to think these are middle-aged individuals who are probably just doing some sort of work, computer work, labor work, things like that. Active movement causes pain because it's contractile tissue. Passive movement may cause pain. So if we stretch the areas that are involved, meaning full wrist flexion, so we're stretching the extensors with pronation and elbow extension, those combined movements, this may reproduce pain. Resistive isometrics hurt, so resisted wrist extension coupled with elbow extension reproduces pain. The elbow joint movement should be full and painless, so elbow flexion extension should be fine. Pronation, supination should be fine for the most part without resistance. It's just wrist extension is the main thing that hurts. One of the hallmarks, though, is palpation that's tender at the lateral epicondyle. And this is usually either at the tip of the lateral epicondyle or just distal to it in what we know as the common extensor tendon. And so functional implications here, you're going to have pain with pinching, squeezing, holding heavy objects and wringing out towels, things like that, and may lose grip strength and things of that nature because of pain. So possible contributing causes include occupations that require repetitive use of hands, like keyboard work, farming, carpentry, plumbing, sports that include a lot of gripping like tennis or golf, bowling. Think about bowling. Your wrist is extended as you come through, right? So you get that chronic extension. And weightlifting. So differential diagnosis, a lot of different things. Let you guys read through that and try to also think through that of why those may be considered differential diagnoses for this. So what are some tests and measures you can do? Well, palpation directly to the lateral epicondyle or the common extensor tendon. Cozen's test, which is the picture on the top. You're going to resist wrist extension. It's basically say, don't let me push your wrist down. They resist you. You're palpating lateral epicondyle. If they have pain in that area, that's a positive test. Mills test is this picture in the middle. It's just a passive wrist flexion stretch, stretching the wrist extensors, which attach into lateral epicondyle. And because this is a two-joint muscle, you're going to extend the elbow as well. And then Maudsley's test. Maudsley's test is a test for extensor carpi radialis brevis irritation, and extensor digitorum communis as well. So you have middle finger that you resist. Move this. You resist middle finger extension. If they have pain at this area, it is a positive test. And of course, you want to rule out cervical spine involvement, so you should screen the cervical spine as well. What do you do for interventions with this? Well, if this is true tendon issue, then we want to start working the tendon with time under tension. And you can do that through isometrics or my go-to is negative work or eccentric work. So eventually you're going to globally make the forearm stronger, the wrist stronger, elbow stronger, shoulder scapular muscles stronger, and all of them more flexible. However, one of the go-tos is eccentric resistive training and gripping. So I will tell you, lateral epicondylalgia is one of the most frustrating things that I treat. It is chronic. It seems to how should I say this? It seems to be really hard to eliminate. I have people that are very diligent with their home exercises that don't get any better. I have people with that don't do their home exercises that get better quicker. And so this is one of those diagnoses that I think natural history is a big part to play in this, and our job is to just not screw it up. And so as long as we're giving them things that we know will make them more resilient to stress, I think that's the best thing we can do from over time. But this is a tough one. This is tougher than medial, tougher than the other tendinosis stuff we'll go over. It's just a hard one to manage in most people. So, but these are some ideas of things to do, and this is what I would do. So you can save this for your files, with the caveat that some of my people get better and some don't. So there you go. We'll go into medial epicondylalgia next. So this is tendinosis of wrist flexor tendons that attach at the medial humeral epicondyle. So we just flip over and do the other side of the elbow, and here we are. Its involvement of the common flexor origin, carpi radialis, and humeral head of the pronator teres. So some people call this a flexor pronator issue. As you can see, that these muscles blend in together and form what we call the common common flexor tendon. The opposite side is the common extensor tendon. And pronator teres is one of these muscles that also help. So pronator teres runs from the radius to the medial epicondyle and allows you to pronate your forearm, of course. And so that may be common site of issue as well. So this is repetitive overuse of those tissues. So we think, again, this may be caused by tension overload or repetitive microtrauma of the flexor pronator musculature. And again, usually affects middle-aged people. We can see it in people age all the way from 12 to 80. Usually those youth individuals, younger individuals, are individuals who are involved in sports or weightlifting that might bias these muscle groups, the flexors and the pronators, like throwing or swimming, or trying to think what else, even tennis. This is also known as golfer's elbow, and I actually see more lateral epicondylalgia in golfers than I do medial, but for what it's worth, golfer's elbow. And again, males and females equally affected. 75% of patients are symptomatic in their dominant arm. So much like the lateral epicondylalogia, this could come on with insidious onset. No true mechanism, however, repetitive overuse over time may be the culprit. The big hallmark here is pain over the medial epicondyle, also about a centimeter distal. So we have the medial epicondyle here, and so if we go distal to that, which would be, this is the forearm, this is see the bicep here, okay? So you go distal to that, in this area, we will see tenderness there, and that's your flexor pronator, common flexor mass, if you want to call it that. So pain is usually related to wrist flexion and pronation, especially that combination of movement. And passive wrist extension with supination and elbow extension may reproduce pain, so that's another hallmark as well. So if you think of what you learn about lateral epicondylalgia and flip it, you can probably diagnose medial as well. So contributing causes of this, again, occupations that may require repetitive use of hands, direct trauma or to the tendon or the wrist, sports like tennis, golf, bowling, football, archery, weightlifting, baseball for sure, farming, carpentry, plumbing, mechanics in terms of occupations. So very similar to lateral. And then differentials will, have you go through this list as well. What do we do for special tests here? Well, we have two tests. They're both named medial epicondylitis test 1 and 2. Number 1 is the active resisted test. You can kind of coincide this to Cozen's test for lateral. This is the active resisted test for the medial side. And then, of course, the passive test for the medial side is much like Mills' test. So what you'd notice about this picture at the bottom is that this is going to go into wrist extension in a second here. So they take, let's see if I can get here, boom, extension, right? Extension of the wrist. There we go. That's why I have this video, so I can show you cool stuff like when I do wrist extension stretch. So what do we do for interventions? Well, I find that the flexors and pronators of the forearm are much more robust and able to take strain and load. And so I find myself loading these individuals more than lateral. And they seem to not get as aggravated or irritated with resistance training as lateral epicondylalgia patients. So, but most of these exercises are very similar. You just focus on the flexor and pronator side of things instead of the extensor side of things. So you would include flexion, pronation, ulnar deviation, and then to well round it out, of course, you do wrist extension, radial deviation, supination as well. And then really you have to take into account these individuals' occupation or sport and individualize the program for them. So that's the best way to treat medial epicondylalgia. So now, next let's talk about distal biceps tendon issues. We'll talk about tendinosis and tendon rupture. So tendinosis, just by the nature of the word, osis is just chronic inflammatory response, right? So distal biceps tendinosis would be a chronic distal biceps tendon issue. This has been associated with manual labor work or heavy repetitive elbow flexion and supination. Also associated with things like gymnastics, weightlifting, bodybuilding, rock climbing, throwing sports. So repetitive activities that require increased supination, like turning a screwdriver or with elbow hyperextension, are types of the mechanism of injury here. Patient signs and symptoms. Pain is usually located at the anterior aspect of the distal arm, right in the kind of antecubital fossa area. Tenderness palpation of the distal biceps belly, the musculotendinous portion of the biceps, or the bicipital insertion into the radial tuberosity all may be areas that are tender. And then pain reproduced with resisted isometrics of elbow flexion and or supination, and pain reproduced with passive shoulder and elbow extension. So again, we think about two joint muscle like passive insufficiency, and that puts the biceps on more stretch, which may cause pain at the insertion site. So what we do for treatments here, really it's all about conservative treatment. Try to regain strength, endurance, flexibility of the flexor supinator mechanism. Strengthen the shoulder. Do things like E-stim, moist hop pack, cross-friction massage, trigger point, elbow joint mobs, and of course, this is eccentric training all day for me. Don't forget about supination, supinator strength. That's actually the main action of the biceps brachii is supination. That's where it's the strongest. It is a helper with elbow flexion, despite what we think. Surgery is not typically indicated here, but if conservative treatment fails and this tendinosis ruptures, then usually surgery is required for a distal bicep rupture, excuse me. So let's talk about biceps rupture then. So distal biceps tendon ruptures, rupture of the biceps brachii tendon, either complete or partial at the distal insertion site into the radial tuberosity. And so distal rupture will cause swelling, bruising, and a gap in the front of the elbow, which we call Popeye deformity, which is created by the absence of the tendon. And so recoil of the muscle belly because there's no distal attachment site. Avulsion of the tendon from the radial tuberosity may also occur. And you can see some pictures here on the right of your screen of the obvious gap here, and then the bruising here where the distal bicep tendon was. You can see the retraction, this Popeye deformity. So essentials of diagnosis, you're going to take history and clinical. Usually there's a bulge left by the deformed muscle, palpation and gap of the elbow. We've talked about this already extensively. Partial tears can be harder to diagnose, may require manual testing the bicep muscle, and I'll give you some special tests to look at that. So general considerations here. So Smoking affects overall nutrition of the tendon, so this may happen more in manual laborers who are smokers in their middle age, or it also may be due to bodybuilders or extensive weightlifters who are pushing the limits of their physical capacity and or using anabolic steroids. And so anytime we see these big tendon issues, pec tendon, subscapularis, biceps, triceps, if it's a big bodybuilder type of individual, then we may suspect anabolic steroid use. So signs and symptoms, pretty obvious. Patient will have an audible pop, typically with this injury. Sharp sudden pain in the upper arm, ecchymosis, swelling, bulging of the upper arm, pain and tenderness, diminished strength with elbow flexion, supination. This bulge is called the Popeye deformity, of course. And so very obvious sort of situation here. So the differential here is on the right side of your screen is not very hard. Not many differentials that have this presentation, but maybe upper anterior arm compartment syndrome. You know, if I had to think of something that might be causing swelling, pain, etc. You could also have, as I'm thinking about it here, something like rhabdomyolysis, where you don't have the pop associated with it, but you have extreme workout or something like that, where your bicep has engorged and causes pain with movement and tenderness and that sort of thing. So maybe localized rhabdomyolysis. So you can see the contributing causes here as well. What do we do for tests and measures? Two main tests here, the biceps hook sign and the biceps squeeze test. And so the hook sign, you can see you're literally going to try to hook under their distal biceps tendon. If you can get your finger underneath of an obvious biceps tendon, this would be a negative test for a biceps rupture. And so what I do is I document this as biceps tendon intact. Try not to put a negative or positive associated with a hook sign, because depending on how you're thinking about it that day, the biceps hook sign is negative. Oh, that's a biceps rupture. No, it's a negative test, which means, anyways, you see where I'm going with this rabbit hole. So biceps squeeze test is a muscle compression test. And so what you'll learn is that we do this a few different areas of the body, one being the calf, and we're trying to assess for a Achilles tendon tear. We'll get to that in musculoskeletal 2, I believe, is lower extremity. But anyways, you would squeeze the muscle belly and try to elicit that muscle's action. Meaning, if you squeeze the biceps muscle, is the primary muscle for supination, you would expect that there may be some supination that occurs when you manually contract a muscle by squeezing it. So you position the patient seated in pronation and you squeeze their biceps brachii and you're trying to assess if their forearm slightly supinates rather, right? Sorry for that miscommunication. You're trying to see if their arm slightly supinates. If it does, you may suspect that their biceps tendon is intact. If it does not, you would have to have further investigation. This I found is a hard test to perform, and I like the hook sign better. So another one is strength loss and supination and elbow flexion, of course. So what do we do for treatment? Well, some people do conservative treatment. This individual on the right certainly did. They just live with it. You have other muscles that assist with elbow flexion strength, and the biceps brachii is not the primary muscle here. This guy still looks like he's good mass here, considering he tore it. And what will happen is the distal biceps tendon will retract, but it will also eventually just scar down somewhere. And, it's just going to be what it is, essentially. You can live with it, but some people don't like the cosmetic look of it. We do know that surgery is indicated for younger active individuals because if it's not repaired, you will lose about 30% of your elbow flexion strength, and you'll lose 40% of your supination strength. So you will have functional implications here. So in the surgical lecture we'll go over at some point, we'll talk about distal biceps tendon repairs and what that procedure looks like, and what a course of PT would look like for that. All right, very good. And the last thing we're going to go over here is distal triceps tendinopathy. So just think of the biceps and then just flip the other side, and you can probably see where this is going. So distal triceps tendinosis, very similar background to biceps tendinosis. Chronic or repetitive strain of the triceps tendon can occur with things like weightlifting, boxing, gymnastics, throwing sports, anything that involves repetitive elbow extension, especially making impact with something. And so patient history, signs and symptoms: localized tenderness of the triceps insertion, maybe posterior elbow pain, aggravated symptoms with resisted elbow extension. Conservative treatments, we're looking at activity modification, therapeutic exercises focused on strength of elbow extensor mechanism, and then eventually closed chain elbow strengthening. Eccentrics as well. Not a lot to do there. I mean, that's something that I think it sees us more than we see it, and usually clears up pretty well with activity modification. All right, and last here is a distal triceps tendon rupture. And sorry if you can hear some background noise. I actually have, looks like a couple guys from the HOA out doing snowblower stuff with all the snow here. We got a lot of snow recently. You can hear somebody shoveling right near my front door over here. So anyways, if you guys can hear that, then hopefully they don't rupture a biceps tendon shoveling snow, because I probably wouldn't be able to help them. Anyways, so as we move on here and looking at the tricep, so very similar presentation as the distal biceps tendon rupture, the distal triceps tendon rupture, and relatively uncommon, however. So this usually occurs when a deceleration force occurs during elbow extension or with an uncoordinated contraction of the triceps muscle against passively flexing elbow. Meaning, I've seen a few of these in my career, okay, post-operatively. The common theme here is they're landing in a sport on their arm, their full body weight or with another individual's body weight as well on top of them. They're trying to brace for impact. Their hand hits the ground. They go into this eccentric elbow extension under load as their elbow is flexing, and it just pops. And so you can kind of see how that mechanism would occur. So this is usually how it presents. So this is someone laying on the table, of course, and this is what their elbow looks like. Big swollen ecchymosis. Kind of appreciate here maybe some tendon retraction. What I've seen is it does not retract as much as the biceps does. So usually this happens with a fallen outstretched arm, of course. I just mentioned that, with enough force to be incurred on the distal triceps tendon to cause a full avulsion off of the olecranon. And so people feel a pop, they'll have swelling, ecchymosis, and a remarkable gap can be palpated. So a significant reduction in extension strength is normally present, but complete loss of active extension is only seen in about 1/5 of these patients, meaning even if they injure it, they may have some fibers intact that allow them to continue to extend their elbow. However, usually they cannot extend it against gravity. And this is usually seen in 30 to 50-year-old men, and usually ones who are chronic, how should I put this? I don't want to pigeonhole anabolic steroid users very much, right? But it takes a lot to rupture this tendon, which is why it's an uncommon one. But I've seen several in my career, and if you're going to get into orthopedic or sports medicine with the elbow, you will need to know about this injury, which is why we go over it. So without further ado, let's move on. Signs and symptoms: pain in the posterior arm and elbow, pain with resisted elbow extension or passive elbow flexion. You might have complete tear, may have loss of elbow extension strength, and of course bruising and swelling, which is layman's terms of how to say ecchymosis and effusion. Differential diagnosis, triceps tendonitis, right? Especially if they have good strength, but they just have pain. Maybe they have partial tear. You may suspect that it might be tendonitis instead of a tear. So you need to mark that off. Radial nerve injuries, right? Triceps is innervated by the radial nerve. And in something like a midshaft humerus fracture, the radial nerve is traversing in the posterior humerus in the radial groove. It's when you have a humerus fracture. We worry about the integrity of the radial nerve as well. And so not only is that its own differential, but you could have the similar mechanism, land on an outstretched arm, feel a pop, and your tricep doesn't work. It's like, well, maybe it's bony, nerve, or muscle. And then, of course, olecranon fractures as well. So this is an extreme picture. I thought I'd throw a bodybuilder picture in there. Some of you guys in class know who this is. It's on the tip of my tongue. Doesn't matter, I don't think. Lee Priest. Yeah, see, as I think and talk through it. I think that's his name, Lee Priest. Old school bodybuilder, but you can see his tricep tendon very well. He's so lean. And, of course, the use of performance-enhancing substances has helped him gain a lot of muscle mass, including his forearm, which is just all we can say is remarkable. But this is a famous picture because of how much of this tricep looks like a horseshoe. And so a well-known picture here of the tricep. So I thought I'd throw that in just as an extreme sort of situation with evaluating triceps. But what are tests and measures? So I call this the triceps lag sign. It's the inability to extend elbow against gravity. So if someone comes in, you suspect that this is the injury, or you're covering an on-field event and someone lands on their arm and felt a pop, say, okay, well, I need you to try to extend your arm. And so what you do is you can have them lay on a treatment table with their arm off the edge of the table and just see if they can extend up and lock their elbow out against gravity. If they can't, they'll get to a certain point and they just can't get any higher. That may be indicative of a triceps injury. Sometimes people will do overhead extension. I like the prone version better, but there you have it. Subjective history, bruising and effusion, palpation of a defect in the tendon, and noticeable tendon retraction. So those are test and measures you can do. What do we do for intervention? This is almost always surgery. You'll have a significant loss in elbow extension strength long term if this tendon is not attached to the bone. So this is what a surgical incision site looks like. It's a curvilinear incision to get around the olecranon, and we'll go over this in our post-operative lecture series for the elbow. So thank you guys very much. Email me with any questions. Appreciate your time.